Hello and welcome to Conversations with Esther tonight. This is 30th of October 2024. Our conversation today is on supporting employees and colleagues who have breast cancer. Now, the doctor is in the room, so we'll just kick off. We are live on YouTube, Conversations with Esther. So allow me to pray and then we can kick off. Father, we thank you for this session. We pray that you will go ahead of us and that we will be able to learn and impact other lives in Jesus' name. Amen. So let me just put up my screen. I believe you can see this just for the intro. To introduce Conversations with Esther, for those that may be joining us for the very first time, Conversations with Esther is an impact-driven professional platform that informs, educates, and rebuilds mindsets. We ignite ethical and authentic leadership, promoting best practice within industries. And when we talk about best practice, we also talk about supporting colleagues, supporting employees that are going through different issues. And this is one of them. Breast cancer is one of them. Conversations with Esther equips the workforce with relevant legal, human resource, and holistic wellness skills through capacity building, training, motivational talks, end-to-end HR consultancy support, and mentorship programs. Now, guided by our three values: integrity, excellence, and impact, we envision a workplace transformed by candid conversations, respectable relationships, and intentional leadership. Now, these are our YouTube, our social media handles, YouTube Conversations with Esther Katiba. Make sure you subscribe and also watch our previous conversations. Even this conversation will be there. LinkedIn, let's connect, let's talk. At Esther Katiba, just give me a message there and let's continue the conversation there. Our Instagram is at Conversations with Esther. Now, this is what we have today. Kindly, let's mute. Our conversation is around supporting employees who suffer from breast cancer. Our guest, Dr. Harish Nagraj, is in the room. He is a consultant and HOD nuclear medicine and PET-CT, Kenyatta University Teaching, Referral and Research Hospital. Now, no one should face breast cancer alone. Breast cancer is the most common cancer globally, with around 2.3 million new cases every year. It represents 1 in 8 cancer cases in both sexes and a quarter of all cancers in women, with 70% mortality occurring in resource-constrained settings. And this is really where my focus is, Daktari. Especially in resource-constrained settings, we need to really talk about that because it seems we are around there. As Conversations with Esther Katiba, we are committed to promote holistic wellness, support and address disparities by highlighting the importance of patient-centered care, including medical, emotional, psychological, and social support in the workplace. Now, this is our guest for today. Dr. Harish Nagraj has Masters in Diagnostic Radiology from the University of Nairobi, Kenya. He received the PET, or you call it PET or PET, CT training and fellowship in nuclear medicine at Bangalore Institute of Oncology, India. Additionally, Dr. Harish has a Master in Oncologic Imaging from University of Pisa. He is highly skilled in the interpretation of CT, PET or PET, CT, and CT, with CT and ultrasound-guided non-vascular intervention. His key area of interest and expertise are early diagnosis of cancer by molecular imaging and theranostics. He is an active member of various radiology and oncology societies with a presentation and papers, both national and international, to his credit. We have the right person in the room. allow me to right away give Dr. Harish. Dr. Harish, how are you?
Thank you for the kind introduction, Esther.
Thank
Uh, I
you.
think I think we are, though it is the end of the month, but we still managed to catch up the right time to sensitize
Yes,
our our people so
yes.
that
So you
we don't
can go
forget what we
on.
are supposed to do. Yeah. So
Absolutely.
thank you very much, and nice evening to all who's attending, and then who will also be watching this video on their free time. And kindly allow me to share the presentation. Are you able to see my presentation?
Yes, we can. You can possibly just put it on full screen.
Okay. Yeah, I think we are good to go. So, yeah. So my presentation today is I'm trying to keep it basic. But now again, I have to, since I'm a clinician, I have to give my perspective, like how to go about breast cancer. As Esther already mentioned, I work at KU Referral Hospital. So this is a very important slide to start with because there is something that Esther mentioned earlier, the resource constraint or lower or middle income countries. Uh, Despite the high disease burden, we cannot afford to kind of do the same thing what developed countries are doing regarding the different stages of cancer. So we have to come up with our own tailor-made setting which suits our region. So the current recommendation, what Kenya National Cancer Screening states, is around 25 to 34-year-old group. The patients needs to do clinical breast examination, that is CBE, uh, probably in every 3 years, or at times you're very free when you're taking bath or something. You can still be checking yourself. And we say that mammogram is not recommended. That's because breast tissues are very sensitive to radiation. So we try to avoid some kind of radiation to that age group. And also, mammogram is not very good for the dense breast. And that is the age group now when the what do you call the mammary glands are very dense, and this also gives chances of missing any subtle lesions. So that's the reason mammogram is not recommended. So when you're going to 35, around 39-year-old now, you do both CBE and then ultrasound or mammography. But from our own experience, I think when you're doing clinical breast examination and then the combination of ultrasound plus mammography, what we call as sonomammography, especially for high risk, the sensitivity and specificity improves vastly. And now the interval is usually 1 to 3 years. But now this age group is a bit critical because they fall between the very young and then the proper screening age. And we kind of use this age group, especially if they have a very high risk or even the fast blood relative patients and probably a high risk or even the history of cancer in the family. And now then going from 40 to 55, now that is when you see what we call as perimenopausal and the menopausal age groups. So that time the CBE, what we call as clinical breast examination mammography, works well, and it's ideal to have it every year. And 56 to 74 years, again the same routine, but now doing it every 2 years. And 75 years and older, now consider individual health factors and women's preference to continue screening because that is not mandatory. And now it's upon the patient's consideration. Now you discuss and try to see whether she's still willing to go for a mammography or probably sonography on that. So these are the current recommended Kenya National Screening Guidelines, and then it was done for the cycle of 2021 to 2025. And after 2025, we are going to come up with new recommendations, if any, from this. So let's take to the breast cancer screening, how it goes. And you have, if you see very clearly, let me on the pointer so that you can. follow clearly.
Don't hold out opportunities. Those are the gateways to.
Okay. So at the PHC, that is what we call as primary healthcare level. This is what happens. Look, education on breast self-examination awareness is quite important, and it can be done by nurses, midwives, clinical officers, medical officers, or even physicians at some time. And once we know that if the clinical examination is positive for any kind of lump, now you'll be referred to probably the county referral hospital, and then they definitely checked again by a gynecologist or even a breast surgeon, whereby now if it's abnormal, that is when now they go into the imaging modalities to further confirm whether it is just a prominent mammary tissue or a lump or any cancerous or any other lesions. So the confirmation is imaging. Once we see something, now you cannot proceed further without knowing the histological diagnosis. So that is when what we call FNAC or core biopsy come. FNAC stands for fine needle aspiration cytology. So at times when the lesion is too smaller, or even if it's like probably heterogeneous in nature, that is, it's neither solid or it's a bit of kind of semi-solid. That is when now the fine needle aspiration comes into play. And the lesions which are more than like 1.5 centimeter, the core biopsy is quite comfortable to actually work with. And once these investigations have been done, if there is confirmation, that is when now you will be referred to the cancer treatment for further, if needed, any further histological correlation or directly for treatment. So when it's negative, it's quite straightforward, isn't it? So once it's negative, you don't have to do much, just reassure, and then we try to be like doing some clinical examinations, just physical examination. Then if it's high risk, including the family history, then you will be subjected to annual screening mammography, which I told you earlier, the tricky age group. So, and that's how it goes. I mean, if it's positive, then there's a way we have to start with the proper diagnostic modality, that is imaging, then interventions like cytology or biopsy. And once confirmed, now that is when you go to the oncologist for further management. So now, again, what I was talking to you, now going further deep into the lesion characteristics. So if it's a simple cyst, just aspirate and drainage, we look at it. And before coming here, there's something mentioned as BIRATS. So I'll just take you back a minute to explain what is BIRATS. So BIRATS is a kind of term used by the radiologist, imaging specialist, whereby we give the level of suspicion based on the lesion we encounter. So if you look at the category here, so we have 0, 1, 2, 3, 4, 5, 6. So as the number increases, so is the severity and the for the positivity. So if you look at BIRATS 1 here, it clearly says negative. So you're looking at a lesion where the chances of malignancy is literally zero, essentially zero. Yeah. So that's what we call negative scan. So BIRATS 2 is very benign. So some of the lesion with our experience and then what do we call lexicon stuff from the mammography as well as the ultrasound, we can clearly make out that the lesion is benign. So in that case, we call it BIRATS 2 lesion. And there are times when you cannot make concretely whether this is completely benign or it's malignant. So those are the lesions. Now it will be characterized further, and either it will be 3, 4, or 3 or 4 basically. So 3 is probably benign. If you look at the percentage of likelihood of cancer, it is less than 2%, but still that 2%. And I have seen cases of BIRATS 3 turning into malignant. But now the catch is once you see a BIRATS lesion, you have to do a short interval follow-up, which we were not giving for the category 1 and 2. Okay. So that is the catch here. So once you see it's a BIRATS 3 lesion, you have a short interval follow-up, 6 months. And once you're seeing that the lesion is not changing much and it's very stable, we don't have to worry much. Now, BIRATS 4 is where we categorize into 3: low suspicion for malignancy, moderate, and then high suspicion for malignancy. So in low suspicion, it is characterized like less than 10% of chances getting to malignant. Moderate is around 50%, and then high suspicion, like it's almost up to more than 50% and less than 95%. So from our experience and also understanding, and also what is practiced worldwide, BIRATS 4 is basically a lesion which has to be biopsied. So the biopsy will never, I mean, you cannot skip the tissue diagnosis in this. So it's clearly mentioned here. There's no role of follow-up. Once it's BIRATS 4, directly go for a tissue diagnosis. And 5, now again the same. It's this time it's very highly suspicious and it's suggestive of malignancy. Again for this, the tissue diagnosis. So more or less, if you look at the percentage wise, like 95%, you're more or less you're confirmed like this is cancerous just by imaging. And now 6 is when you already have a correlation of tissue diagnosis. That is when you will say like, yeah, this is biopsy proven. For example, now the patient before even getting an imaging done had a very huge mass, went to a doctor, then he had removed a tissue, went for laboratory, confirmed breast cancer, comes back again, looks for the lesion, and then we give them an image of the certain cancer, and now we call it as BIRAT 6. So yeah, so I think that one now will sink in. So once we are seeing that if the breast ultrasound, it's more like less than 35 years, I told you the reason, because the breasts are very dense in that age group. So now you are seeing BIRATS 1, 2, or 3, just repeat ultrasound in 6 months. 4 and 5, definitely go for tissue diagnosis. Very clear, yeah? So now core biopsies. If it's malignant, now refer to the breast surgeon. If it's indeterminate, now you cannot make out whether it's cancerous or non-cancerous. So we have to go for the excision biopsy. What is excision biopsy? For example, if the lesion is around 4 centimeter, now you're doing a core biopsy, it can only take maybe a few millimeters. That is what we call as core biopsy. Now, if the core biopsy is indeterminate, that is when now they recommend an excisional biopsy. Excisional biopsy is removing the whole mass and then sending it for pathological review. So that is what is called as excisional biopsy. So that will be more or less confirmatory. And now, if the mammogram, I told you it's recommended after 35 years. Again, if until it's BIRATS 3, just keep repeating until 6 months, observe a routine, and excise the mass. If it's, there are some of the lesions which are considered precancerous by imaging itself. So those imaging diagnostics, we can inform the patients. If they're quite okay, they can discuss with the surgeon and then excise the mass instead of waiting for it to either be stable or turn into malignant. So that can also be done, especially if it's determinant that looks as precancerous. This is just a notes as we are discussing, that it's always recommended that breast ultrasound has to be done by an experienced trained sonographer. There's a reason for that, because ultrasound is a real-time investigation, and also in imaging we need to reproduce something which we have seen, and that's for the same reason that it has to be done by an experienced skilled sonographer. Because you can imagine, if someone calls in a very suspicious lesion, what the patient undergo is completely unimaginable, especially if you're giving any sinister report. So core biopsy especially is important for making treatment, and especially considering different histological type has different choice of chemotherapy, which oncologists usually decide after the MDT. That is quite important. As I mentioned earlier in the previous slide, excisional biopsy is only recommended if the core biopsy results are indeterminate. And health facilities should facilitate triage and prioritize breast cancer patients for timely surgical management to improve clinical outcomes. Now, again, going further, this is clinical assessment. Once you're seen about the nodes, once we are talking before the breast lesion itself, and the cancer spreads through the first nodal, and then could be hematological, and then can also go through a different distant metastasis, what we call organ metastasis. So here, if the clinically the node is positive, usually the nodes first go to the axillary region, the armpits, and if clinician by palpation, if he feels it's suspicious, he'll have probably a small sample of it. And once it is negative, then there's no further action needed in the axillary region. Whereas now, if it's kind of negative, then he has to again look for sentinel node biopsy. What we call it sentinel node is the first node from where the breast cancer spreads. It just gets into the cancerous cell move to the first node. That's what is called as sentinel node. And if it's positive, usually it's if it's in T1 and T2, what we call a tumor less than 3 centimeter, then usually there's no preoperative chemotherapy needed because the size is quite small, and they can go for excision and also lymph node dissection. Whereas if the mass itself is quite big, then they give the chemotherapy just to reduce the size of the mass, and then makes it easy for a good resection of the mass. So universal breast cancer pathway, like how to go about whatever I've been talking previously. So patient interval, then diagnostic interval, and treatment interval. So when the patient is actually in the care of nursing, midwife, and even clinicians or clinical officer, that's the gen. Basically, you will be put into screening after seeing some positive uh, uh, signs and symptoms. And once it's negative, you just have to follow up, if at all, if there is any concerning history, as in family positive family history. Otherwise, just the diagnostic interval, as I told, if there's any abnormality, we'll do the tissue diagnosis, and once the diagnosis approach, then we are going to go the oncologist way. And once the cancer, we find out that it is a localized disease and not spread to distant organs, be it liver, bones, brain, or any other part. Then we definitely have a curative therapy, what we call radical therapy. It could either be surgery, radiotherapy, or at times systemic and supportive services. Whereas if once you know that the disease are already spread, then you cannot go radically to each part to treat the disease. So you rather go for palliative care and do the pain management and end of life care. That one, with the current situation, we are not seeing that many palliative kind of care at our center. We usually are picking the disease in a pretty early stage than what we were doing 2 years back, and that is because of our increased accuracy in diagnosis these days. And once the diagnosis is confirmed, also the treatment becomes easier, especially if it's early stage cancer. So that is one thing which we are doing right. And that's it about from my end. I'm open to questions.
Wow. Thank you, Dr. Harish. I don't know, anyone on the call that has something to ask before I go to what I was going to ask on the side. Hi, Mercy. I see Jane, Godwin, Ayaga, Knight. Do we have a question? Sabina, we can unmute. If you have a question, you can even unmute or comment. Yes, Sabina.
Wow, that was profound. Unfortunately, I joined late. Thank you, Dr. for that. I missed on the that introductory bit where you had projected the age groups and the type of screenings that should be done. Like I fall in that age bracket of 40 and something, and I would really want to know what exactly that CBE meant. Thank you.
So as I was explaining, CB is clinical breast examination. And now you said, if I'm not wrong, you said you were in around 40s, 40?
Yes, I am.
Yeah,
And
so
I've never done any screening, so I'm interested.
yeah, so I think for you, best is to just be doing a clinical breast examination. It could still be a self breast examination, or by why we call clinical is now if it's done by the nurses, midwife, or the clinicians. If they find out any abnormality, that is when now you will go for the sonography, what you call ultrasound, because 40 early 40 is still the breast tissues are quite like glandular, and then there is no significant role of mammography in that age group, and also the dense breast. So I would prefer you rather have sonography. I mean, once a year should not be a problem, especially if you have any strong history in the family, if someone has breast cancer.
Okay,
I think I've answered.
that takes me to the next question. If actually in the lineage there has not been any cancer illness, is it still something to worry about? Should you like do that regular screening, or once in 5 years is okay?
Now 5 years is a too long gap, and then you see, as much as we don't have history of family history, but we are very prone to the lifestyle. What we had now is very different from our grandfathers and great grandfathers who had, I mean, grandparents who had. So we are more prone to uh, be it food, stress related, and other comorbidities. These all contribute in a way or two. So I wouldn't recommend 5 years is a quite a long gap. You rather do it annually, because now this for your age group, clinical breast examination and sonography doesn't have any radiation risk, so it's quite safe to get it done.
Okay, Sabina, that's okay. She's gone on mute. Now, Dr. You mentioned something before I give Mercy, and I know Mercy, you can prepare to speak. You talked about foods. Now there's a lot going around. You're told, don't eat this, don't eat this, don't use microwave, don't do this. I mean, like everything is, we shouldn't use it, Dr. Please guide us. Guide us. Yeah.
That's currently I mean, that's, yeah, it's a hot topic, and but currently, with the current resources available, I think it's good for us to not, instead of what not to eat, we have to choose what we eat. So when we when we are eating, we try to be more natural as possible, and also hot food, instead of going for a lot of foods which have preservatives, and also processed foods. So that is one thing. Usually, they actually link with cancer, carcinogen, what I'm saying, and also to consume a lot of fruits and vegetables which are rich in antioxidants. Antioxidant properties are very important, especially for if you're looking for uh, to make the cancer away from you. So we need to take a lot of natural fruits, vegetables, and which are like, probably if you're talking about antioxidants, the rich vitamin C rich foods, be it grapes, oranges, berries. These all really help. These contribute to for us to, and even the citrus, it helps for loading us with good antioxidants in the body.
Good. Mercy?
Good evening, everyone.
Good evening, Mercy.
Okay, well, I'm a breast cancer survivor, 1 year now. And I will say it is not an easy journey, but early screening is very important. Myself, I never went for the screenings until I had a lump in my breast. That's when I went, after I saw the lump, I stayed like 2 months. Then I went for the screening, for the mammogram. Then I was told I was at stage 2. So I started my treatment here in Kenya. But unfortunately, I got very unwell. So I had to be taken to India. And I did mastectomy. Oh, the journey is not easy. I went through so much, especially after mastectomy. Right now that after mastectomy, now knowing that you're living with one breast is very challenging. But I thank God for my family and the people that I work with, my bosses. They've been very supportive. Though at times you will feel like you will feel lonely, and you feel, because I'm still taking the medicines, tamoxifen, which I'll take for about 5 years. So I've only done 1 year with the tamoxifen, not 1 year, almost 8 months with the tamoxifen. So at times you feel lonely, at times you feel like crying. Yeah, but I would like to tell anyone who's newly diagnosed, the journey is not easy, but they will make it. Thank you.
Wow. Wow. Daktari?
Yes, I think
Mercy brought in something because it's on the support, how as family and also the workplace, how can we support our colleagues?
I think to be honest, this thing, the cancer is not disease for an individual. It's a disease which the whole family actually face off. So the support both at workplace and families is needs to be enormous for someone to win the journey, as like the way Mercy has done. Uh, Also, a small bit of understanding, awareness is very important. That's the reason, like for us in the hospital setup, at least most of them are not that naive. They know what's happening around. But if you go to a completely non-medical organization or setup, then it becomes a bit challenging for them to understand, because unless now a person has someone in the family, he will not understand the pain of what other one is going through. So the support which at workplace, which the patient gets, is quite important, and that can only come with awareness and also sensitizing. Like now you have to sensitize the patient, like be it workmates and there's no harm in like going open saying that I have so and so disease, and so I need support. At least first they can open up with senior officials, which I think, Esther, you can also chip in later to tell whether it's fine, because there are some illnesses which you don't want to disclose. But again, now if it in fact impacts the daily routine and work, then it becomes quite important to let know what you're going through, because your performance might be reduced because of the same thing, and you're not the same person who you were before. And I can actually remember, as I'm talking, there was one of the nurse who was very active, and but the unfortunate bit was she was very secretive. She didn't disclose with anyone of us. And by the time we diagnosed, she was already stage 4. And as I mentioned earlier in my slide, stage 4, and if the disease burden is quite high, it becomes really challenging, because now the medicine which we are giving might work or might not work. We don't know. She was working with the help of management and her supervisors. She continued working well, but eventually she couldn't make. I think she survived for around 6 months for stage 4, but she was working still. Why I'm saying this is, if it can happen somewhere who's working in the hospital setup, then the chances of having like patients being secretive, it's even more in other set. So this thing of this taboo should actually it should come out, and then people should start normalizing it. Like if you're a patient, it's still normal. I mean, it's kind of any kind of disease. Now the reason for that is being like the, as Mercy told, stage 2 and still ending up with what she had. But if you look at it, the survival rate is very high, especially if you're spot on diagnosis and the treatment. The curative rate is almost 100. So I mean, it's one way it's good, but now as the question comes back again to you is, how are HR policies in the country? Does it differ in each organization, or maybe you need to also tell us about that. But from clinical point of view, yeah, I think it's high time that we support each others, and then there should not be a stigma, or there should not be any discriminations based on whether she's able to perform or not perform, mainly because of her current illness. Thanks.
Good. And as you talk about the policies, I think it's every organization customizes their own policies. You see, there's an Employment Act that stipulates how you deal with people who are unwell. But I think, as I've always said, it goes back to humanity, just treating people well. Because today it could be Mercy, tomorrow it could be you. So it's just important that when we structure and when we design our policies and processes in the workplace, that we support employees that are going through any illness. I know there's a lot of stigma as well in mental health. And you see, the thing is, I think also people are a bit, maybe because we've not been sensitized and well-educated, Daktari, people can really get a bit unprofessional in speaking about cancer in the workplace. You know, people even make comments, that this, you see, when I hear people talk about corruption and say corruption is a cancer, my mind immediately goes to someone who could actually be suffering from cancer and is listening to that conversation. I think people just need to really be very sensitive to how we deal with it. Mercy, maybe as we come to winding up, I want to ask you something. What support, maybe you'll be able to also help most people in the room. What support did you get from your employer? I heard you say that your employer was very supportive. Was it extra leave or additional sick leave days, or is it a medical cover, or what was it?
Okay, when I got sick and I was admitted, I stayed out of work for 8 months because I went to India. I stayed in India for 4 months, then came back, the recovery. So for those 8 months, I was being paid full salary. And then when I came back also, they helped me even with the treatment, with the billings. They were always there. They were calling me every time when I was in hospital. They were visiting. And it's not only them that really supported me. Also, my kids' school, which is Harambee Primary, there's a teacher there, Mrs. Musioki, who also really supported me with the kids, encouraging the kids. So my kids never felt that I'm far away from them. Also, my workplace, even up to now, I always have that leeway of I can go to work late. I can always call them and tell them today I'm not feeling well. I'll come at around 11 and they're okay with that. And when I go to my appointments, I tell them at around 12 I'll leave. They say it's okay. They give me a vehicle. It takes me to hospital, brings me back to work. Yeah, so I thank God for them. That's how they really support me.
Wow, wow. Congratulations. I don't know who your employer is, but that's an amazing employer. I think we need to
Yeah.
recognize them.
Apparently he's an Indian. Ultra
Yes.
Multiwear Suppliers. He's an Indian.
Ultra what?
Ultra Multiwear Suppliers Limited. We deal with spare parts.
Wow.
That's very
Wow.
nice. I hope people they take leaf out of these kind of institutions. This is really nice to hear,
Yeah.
and
Amazing.
it makes people life more colorful. I mean, especially when they're going through such bad phase,
Yeah,
and
true.
it really adds up to what the vision of both patient and, I mean, employer as well. This is something like which I always felt. If you get the trust of employee in such a way, then you will never lose them. I mean, it's
That's a
just like
thing. That's a
yeah,
thing, Dr. You see, then you build employee loyalty and employer branding, you see, because
absolutely,
you care. You see, we talk about employees are not just looking for money, they're looking for an employer that really cares. And I congratulate Ultra Maltware for
Yeah.
that, because it completely shows that they care about the employees. Unfortunately, most organizations will come back to you and say, sick leave is up to this point and the law states this and this, so we need to separate. You see, and that is the moment when the person needs you most. It's when their family needs you most. Congratulations to them and thank you. And also Harambe, I happen to sit in the board for Harambe Primary. I'm impressed, Mercy. Thank you for that. Thank you for
Thank
that.
small world. Yeah.
I know.
Yeah.
Yeah, so it's amazing. Anyone else with something? Mercy, your story is encouraging. Thank you. Anyone else who has a comment? I know Daktari has a meeting in the next 5 minutes.
Esther?
Yes.
Yes,
Night.
it's night again.
Yes.
I want to thank Daktari for that presentation. And thank you, Esther, for this is something on time. So my concern is, as a HR in our workplace, I don't think there is any policy dealing with cancer at the moment. And again, I was just wondering, when we are having that breast cancer day, would Daktari consider maybe doing an awareness for HR practitioners so that we are able to move from sympathy to empathy? Because the two terms will exhibit different feelings or different expectation or different realities from those people who are suffering from cancer. So it is a cry as I come before you, but sometimes when we are in our workplace, the people who are going through that situation might not be willing to open up. And then when they fail to open up, we may not realize and we may not step in even to support them. But I think what should be key as we go on forward, let there be clear creation of awareness so that we are going to move from sympathy to empathy, such that mtu anapokuwa kazini, sometimes when you sympathize so much, wanasikia like, it's like I'm going to die the next week. But when you are empathizing, and we are able to make them feel comfortable in the work environment, and we are still that, and to make them feel we still need you and that you are still able to give something back, I think that is key enough. Thank you so much.
Absolutely, absolutely. I see Godwin. Godwin, maybe in a minute so that we don't keep Daktari. I know we actually pulled him from a meeting for this conversation. Godwin. Godwin, you can unmute. Okay. Hi, Godwin. Oh, he's dropped. But thank you, Knight. I hear you, and I think Daktari, are you okay sharing your contacts or where they can find you?
Yeah,
I think
sure.
it's also good that they engage you and their organizations so that you can be able to speak to them.
Not a problem.
Maybe on the
This is what
chat.
I'm saying. Like, we need to bring the awareness as much as possible so that everyone benefits. Sure.
Yes, you can do that on the chat, maybe. And because
I'll pass. I mean, you have my contacts. I can probably,
yes,
or else you can just give her contacts. Then I
yes,
can get in touch.
that's fine. Knight, you can have a chat with me, and anyone else, you can reach out to me on my number. Possibly you. Let me just put my number there. I think that's easier, Daktari.
If they have any questions, I can also put my email just to make sure if you can write the questions there.
Yes.
Becomes easy.
I think actually your email will work better. Yes.
Yes.
Yeah, kindly pick that email address. I think by just coming into this call, then you're able to access Daktari. But thank you very much. Thank you, Dr. Harish. Thank you for always coming in. I need to say this, Daktari is never paid to do this. He does this as he's giving back to the society, and we really appreciate you, Daktari. Thank you very much. Thank you everyone for showing up. Please go to our YouTube channel. We are live on YouTube, and share this conversation with as many people as you can. Let's sensitize people. Thank you very much, Mercy. Thank you, everyone. Thank you, Daktari. Good night. God bless you.
Thank you, Esther. Thank you, Mas. Thank you, everyone. Nice evening all. Bye.